This recorded lecture is for oxygenation and the pulmonary system. Let's first talk about how gas exchange occurs. Oxygen will enter in through our nose or mouth when we breathe in air. From there, it moves through the airways. It'll first go through the trachea, then make its way to the bronchi, then the bronchioles, and then end up at the alveoli, also known as the alveolar sacs. From there, oxygen can be carried to organs and tissues, but we also have some waste products that will be exhaled through the lungs, which is CO2, or carbon dioxide. So basically, this waste product is going to move from the blood to the lungs so that we can breathe it out. Now, if you have someone who has a respiratory condition, such as COPD, it can restrict the ability of the body to get rid of that waste product. Some common respiratory problems are obstructive airway disease or restrictive airway disease. The big difference here is the pathophysiology behind them. Your obstructive airway diseases, such as COPD or asthma, is going to be more of a retention of the air inside the lungs. So basically, the individual cannot expel all of the air when they exhale, which means that they're going to have higher levels of CO2. Whereas a restrictive airway disease is going to be a reduction in the lung volume because we will have more stiff lungs, meaning we lose some of that elasticity. Another way to think of it is your obstructive airway disease is more of an issue of shortness of breath related to inability to exhale air, whereas your restrictive disorder is going to be a difficulty in breathing in air, so receiving oxygen versus expelling the CO2. With obstructive airway diseases, we have air trapping, which again is essentially a retention of air, particularly CO2, in the alveoli. And this is going to potentially cause a narrowing of the airways, especially if we have increased secretions, as you might see with chronic bronchitis or asthma. This is ultimately going to lead to an airflow limitation, again, particularly with exhaling air. With your COPD or asthma patients, they cannot, again, exhale the CO2 or all of that extra air as well, which means it just kind of hangs out in the alveoli, which is ultimately going to lead to the remodeling that can occur. With COPD, do keep in mind there are two different forms. There's chronic bronchitis or there's emphysema, and we'll touch base on what the difference is between those. The other hand is your restrictive airway disease. So things like pneumonia, lung cancers, tuberculosis, or even acute respiratory distress syndrome, which is ARDS. And this is going to be a restriction of the lung expansion when breathing in, meaning the individual cannot fully expand their lungs with a normal breath of air because of the stiffening of the airway. This is going to lead to a decrease in lung volume because, again, they can't breathe in quite as well as you would without a restrictive airway disease. With these individuals, they're going to have an increased workload of breathing, meaning they're going to be short of breath because they can't bring in enough oxygen. The first obstructive airway disease we'll talk about is asthma. With asthma, this can be a chronic condition with episodes of exacerbations. The one thing to note is that this type of airway obstruction is temporary. If the individual is receiving treatment and the airway is opened up, then the issue resolves. Some people with asthma will have to have preventative treatments in order to prevent that airway constriction, and we'll talk a little more about that. But with asthma, the pathophysiology is basically an exposure to an irritant. It could be from a type of dust, perhaps an allergy to cats, so the cat dander, or it could even be exercise-induced asthma. When the individual is exposed to that trigger, then it causes an inflammatory response, which then leads to increased mucus production and then a narrowing of the airways. If you look at this image down here on the bottom left, you'll see here's a normal open airway or bronchiole, whereas on the right, there's an asthmatic bronchiole. This little area right here is some mucus that's built up, and then of course we have the inflammatory response there as well. Because of this is going to cause the impaired gas exchange. The individual is not going to be able to exhale all of that CO2 because they have inflammation and mucus in the way of doing that. Typically, these individuals will receive something like a rescue inhaler to help open up those bronchioles so that they can breathe or exhale more effectively. Some of your clinical manifestations that you might see in an asthmatic are things like shortness of breath, chest tightness, a cough, wheezing, which sometimes can be inspiratory, expiratory, or both. Some individuals will also have increased mucus production. Some patients will not have all of these symptoms, but may just have a couple of them. For example, they may only feel chest tightness, or they may only have the shortness of breath. With these individuals who have severe asthma attacks, they can also have the use of accessory muscle use. When we see the use of accessory muscles, we really know that this individual is struggling to breathe. So these are the individuals that really need to have some sort of interventions, like a rescue inhaler and oxygen. Some individuals can also have pruritus, which is itching, or rhinitis, which is a runny nose. These are going to be more common for the individuals that have some sort of allergy that's triggering their asthma response. Typically, if an individual has allergens that trigger their asthma response, they also have the typical seasonal hay fever type of symptoms like the itchiness or rhinitis. The issue with the rhinitis is when they get postnasal drip, it can irritate the airway and then cause coughing, cause bronchospasm, and then make the asthma symptoms worse. The longer the individual goes on with an asthma attack, the more severe it can be. It can ultimately result in death if they are not treated, depending on the severity of the asthma attack. Someone who has more long-standing asthma, they can actually get a barrel chest, similar to how you would see with a COPD patient, but this is not quite as common with asthma patients. How do we determine that someone's having an asthma attack? Well, we as the nurse are of course going to assess for those symptoms of asthma, but we may also have some orders to look at things like an ABG. An ABG will tell us how well someone is oxygenating, but also if they are retaining any CO2. If they have a lot of inflammation, again with asthma, because it's an obstructive airway disorder, they will have higher CO2 levels because they can't expel that extra CO2. If they have an allergy-like response or trigger, then we may also see IgE, which is your basically your antibody that becomes elevated when we have an allergy response to something. We may also do pulmonary function tests, and this helps to measure our forced expiratory volume. So we blow out in this little machine as hard as we can to see how far we can move the meter up, and that tells us how well we are able to exhale and get rid of some of that CO2. Treatment is really going to depend on the severity of the asthma. Some patients will do just fine with a rescue inhaler, and they only use it every once in a while when they have some sort of trigger that initiates an asthma exacerbation. But some people who have more mild, moderate to severe will need some sort of control therapy. So this is going to be a prophylactic measure, such as something like Singulair, which is montelukast, or even an inhaled corticosteroid to help prevent that inflammation from occurring. Every asthmatic will always have a prescription for a rescue inhaler just in case they have an asthma attack as well. With the control therapy, this is going to, of course, help to reduce the sensitivity, but also reduce the amount of inflammation that one may encounter. With the reliever drugs, the rescue drugs, so something like albuterol, this is basically going to help to open up and bronchodilate so that we can breathe air in and out, particularly breathing CO2 out more effectively. Those bronchodilators will not be effective on inflammation, but rather it will help to smooth the muscle. It'll help to relax it so that we can breathe out more effectively. It's very important to ensure that education is provided with your asthma patients in terms of how they manage their asthma. First, they need to avoid the potential triggers. One is medications. They shouldn't take anything like NSAIDs, aspirin, or even beta blockers because it can cause bronchospasms and then lead to an asthma exacerbation. Also, certain types of food, certain dyes, as well as certain preservatives can cause a bronchospasm and response as well. Certain triggers can be identified, so it's really important for your patient to identify when they notice that their asthma is being exacerbated. What were they doing? What kind of environment were they in? Were they exercising? Did they recently pet a cat? Were they in a dusty area? Were they around cigarette smoke? So once they identify what that trigger is, it really does help to avoid the trigger as much as possible so that they can avoid the asthma exacerbations. If they have exercise-induced asthma, then they can also prophylactically take their bronchodilator, so something like their albuterol, about a half hour before exercise to ensure that the airways are open and they can exhale the CO2 appropriately. Also, sleep, hydration, and rest, as well as stress and anxiety reduction, these can also help with preventing asthma exacerbations. People who have very emotional fits, for example, let's say someone who is sobbing and crying very hard, or someone who's even who's laughing really hard, that can cause bronchospasm and then lead to an asthma exacerbation. If the individual has identified that there are certain allergens or environmental factors that can affect their asthma status, washing their bedding in hot water can help if they do have more allergy responses that lead to their asthma exacerbations. Now, we also want them to monitor their status. So they need to do their peak expiratory flow, which if you click this will take you to the link to look and see how to use a peak expiratory flow meter. Well, what are we looking at when someone does a peak expiratory flow? Well, they should be doing this 3 times in a row and then taking an average of the 3. They're also going to identify a personal best number. So a personal best is usually indicated or determined when they have the least amount of symptoms. So there's a green, yellow, and red zone. This green zone here means that treatment is effective and they're able to exhale air appropriately. Yellow indicates that, well, they may need to take their rescue inhaler. Their management is probably not quite as effective right now and they need to follow up their primary. This red means that they need to use their rescue inhaler and they should seek immediate medical attention. So it's really important to communicate this with patients so they know when they should be seeking emergency care as well as when they need to follow up with their primary. As I mentioned on a previous slide, there are 2 different subcategories of COPD, emphysema and bronchitis. These are going to be different pathologic conditions, so they have a slightly different pathophysiology. With emphysema, we have an elastin breakdown, which means that the alveoli are going to lose their recoil. So they're going to lose elasticity, which is why there's a lot of air trapping. It won't be able to push that CO2 out of the lungs appropriately. With these individuals, they tend to be called a pink puffer. And that basically means that they are going to have more of a pink appearance. They tend to look older than their stated age. They tend to be underweight and malnourished. They may also have really bad shortness of breath as well. These individuals may also have quite obviously a barrel chest because they are more underweight. With these individuals, they are typically going to show signs of accessory muscle use, which tends to be a little easier on someone who's thinner versus someone who is more obese as well. With emphysema, it's typically caused by a history of smoking or some sort of occupational or environmental exposure that the individual's been around for a long period of time. Chronic bronchitis, on the other hand, is when there is inflammation of the bronchioles and the bronchi. These are the individuals that are referred to as blue bloaters. They tend to have a higher level of hemoglobin. They tend to appear a little overweight, maybe even cyanotic, and they may also have peripheral edema. These individuals are typically going to have wheezes as well as bronchi more frequently than someone who has emphysema. With COPD patients who have chronic bronchitis, they also tend to have a wet sounding cough. So they may have thicker sputum and a chronic cough that occurs. These individuals may also have worsening symptoms with exposure to some sort of irritant, such as cigarette smoking. So some of your COPD patients in general may also have asthma on top of their COPD. So it's one of those, who knows what comes first? Is it the COPD or the asthma? But these individuals also tend to develop their symptoms because of some sort of occupational or environmental exposure or from a history of smoking. With your chronic bronchitis patients, they have to have bronchitis for a minimum of 3 months for 2 consecutive years to have a diagnosis of it. When managing care for a patient with COPD, you need to identify certain factors, such as what are their risk factors? How old are they? The older one is the higher risk of developing COPD versus someone who is younger. Also, gender and occupation. So again, with occupation, even if you have an individual who's retired, you want to ask them, what they used to do for work, because that helps identify, did they have any occupational exposures that could have led to COPD. Also, males tend to have a higher risk of developing COPD versus females. Smoking history is really big because, again, with chronic bronchitis or emphysema, there is a strong link to a history of smoking. So we want to identify how long they smoked for and how many packs a day they smoked. If they have a cough, you want to ask them, do you find that it's better or worse at certain times of the day? Many of your individuals who have chronic bronchitis will tell you that they have a more productive cough in the morning and then it tends to be more dry throughout the rest of the day. Orthopnea would be something that would be concerning because we, of course, worry about things like cardiac function. So these individuals who have orthopnea may need to sleep with several pillows, but they can also sit in the more tripod position as seen in this image here. Tripoding is when you rest the elbows on the knees, or if they're unable to do that, they can lean against a table. Weight loss is something that needs to be monitored, especially for your emphysema patients. The more severe the symptoms are, the more likely they are to lose weight because they can fatigue while eating their meals. So there are certain things that we can do to help promote nutritional intake for our COPD patients. With the diagnosis of COPD in general, we're going to look at several different things, ABGs being a really important one. And typically with a COPD patient, we'll see decreased oxygen as well as increased CO2. A chest x-ray may show hyperinflation and they may have that barrel chest appearance. Pulmonary function tests can be performed in order to assess the lung volume, and this is something that's typically going to be done routinely as well to monitor if there's been a change in how a patient's either responding to medications or if they're having a worsening of the disease process. White blood cells can be done to rule out infection, especially if they have a productive cough. So that may also include doing something like a sputum culture. With your physical assessment with a patient with COPD, we're of course going to assess the respiratory status, but you also need to look at their general appearance and cardiac assessment. With their general appearance, do they have what appears to be a loss of muscle mass, particularly of the extremities? With those who have emphysema type of COPD, they may have more enlarged neck muscles from using their accessory muscles in order to breathe. Do they have orthopnea? If they have orthopnea, then it could be an indicator that they have cardiac issues occurring, such as CHF as well. With accessory muscle use, you can see this especially around the neck and abdomen, which is particularly more common in emphysema patients. Rapid shallow respirations may also be seen, and that's more related to the air trapping because they are unable to expel the CO2 in that air that's trapped, so they can't breathe in as much air. They may also have diminished breath sounds, particularly if they have a more progressed form of COPD. So when you're listening to those lung sounds, if you are in doubt, make sure that you follow up and see if someone else can confirm the diminished breath sounds. When we're monitoring our patients with COPD, we are very frequently monitoring the respiratory status. Some of these individuals may need to have oxygen. Typically with COPD patients, we start low and then titrate up. So we're usually going to start with a nasal cannula at a lower liter per minute range. So typically we'll start off at 2 and then we can titrate up if needed. We are paying close attention to the pulse oximetry, but we also need to pay attention to the respiratory status. If we give them too much oxygen, they can have a decrease in what's called hypoxic drive, meaning that their respiratory rate is going to go down. Breathing techniques to help expel some of that CO2 is going to include pursed lip breathing, which if you look at this image here on the top left, they will breathe in through their nose and out through their mouth through pursed lips. So the lips are going to be more narrowed. Positioning can also be very helpful. So if the individual is able to do a tripod position, then you'll have them do that. If they're not able to, then you can sit them up into a high Fowler's position or into a semi-Fowler's, whatever helps with their oxygenation status. If your individual is, if they have a productive cough, then you want to help them expectorate some of that mucus. So you want them to be able to cough it up. Fluids will be indicated if they don't have any contraindications, but they may also be on something like Mucinex, which is a mucolytic, to help get rid of some of that extra mucus. As mentioned previously, usually individuals will need mucolytics, especially if they have chronic bronchitis form of COPD. This helps to loosen up that mucus so they can actually expectorate it and cough it up. Inhalers may be indicated, and these are going to be really similar to what we would be prescribed for asthma. So they may have a rescue inhaler to help open up that airway, but they may also have something like an inhaled corticosteroid to help prevent the inflammation. So that's going to be more of a prophylactic form. Nebulizers may also be used in order to more effectively deliver some of the medication to the airway so that it can open up the airway, as well as better deliver some of the medications that are going to be inhaled. With our patients who have COPD, we want them to stay engaged and active because this helps to promote circulation, but this also helps to promote oxygenation. So they may be enrolled in something called pulmonary rehab, which is basically the use of exercise as well as education and behavioral interventions to help them maintain physical activity. Their breathing function is going to be really crucial with maintaining exercise. So they may need to also develop ways to cope with their condition, especially as it progresses. With pulmonary rehab, typically they're followed by a team that will help to ensure that the patient is successful and that they have all of the resources that they need. Some of our individuals who have secretions, we may need to help them to suction. Of course, we want them to expectorate their mucus as much as they can on their own, but for those who need it, we will do suctioning as needed. When we are suctioning, we typically want to hyperoxygenate. So we want to give oxygen before doing the suctioning to ensure that they don't become hypoxic. With our individuals who are going to be undergoing surgery, they may need something like a lung transplant or lung reduction surgery. With a lung reduction surgery, they'll basically take out the portion of the lungs that are most affected by the COPD in hopes that there's less air trapping occurring. As mentioned in previous slides, some of our breathing techniques will include things like pursed lip breathing as well as diaphragmatic. So we're using more of our abdominal region in order to breathe better. The purpose of diaphragmatic breathing is to more or less help decrease the amount of shortness of breath that one is experiencing, and also to reduce CO2 retention, especially with your pursed lip breathing. Pursed lip breathing works by creating resistance, by closing the lips a little bit in order to provide that resistance. So again, it's going to help with decreasing air trapping because it's going to prolong the expiratory rate, which ultimately helps to decrease the amount of CO2 one is retaining. Diaphragmatic breathing also helps to reduce airway trapping, but this is going to be best done by laying on one's back and to bend the knees as it is in the image here. With the individual, they're going to inhale through their nose and exhale through their mouth, similar to how they would do with pursed lip breathing, but they're also going to be more conscious of their abdomen rising with their inhalation. So they're going to use their abdominal muscles a little bit more with this. And this will also require them to have pursed lips so that they can help to get rid of some of that extra CO2 and that extra air that they are retaining in their lungs. Now let's talk about our first restrictive airway disease, which is pneumonia. With this, it is going to be caused by an inflammation because of some sort of infectious agent, which could be a bacteria, it could be a virus, even fungi or worms. But there can also be other types of pneumonia, such as aspiration pneumonia. With pneumonia, it's going to lead to an accumulation in the lungs. Typically, it's going to be one-sided, but depending on what's going on with the patient, it could be on both sides. So oftentimes this accumulation of fluids can be more in the lower areas of the lung, but it depends on what type of pneumonia they have. And with this, it is going to potentially lead to what's called sepsis, which is when there is an infection, a more systemic infection that travels through the bloodstream. So it's really important to stay on top of pneumonia and for individuals to receive treatment to prevent things like sepsis. Despite pneumonia being very easily treatable in most cases, it is a major cause of death in the US. especially in our older adult population. And this is because they tend to have a weaker immune system, so they can't fight off whatever the invading organism is. With the etiology, again, it depends on the type of pneumonia. So virus, bacteria, bacterial infections tend to be the easiest to deal with because they can receive antibiotics, whereas fungi or viruses, these tend to be a little more difficult to fight off, especially for someone who has a weaker immune system. With the different categories, there's a community acquired, there's hospital acquired, and there's also ventilator associated types of pneumonia. So those individuals who are on a vent who develop pneumonia. How do we know if someone is developing pneumonia? Well, typically it is going to be a sudden onset, and with our older adults especially, they could have sudden confusion. With our older adults, in general, if they have sudden onset confusion, then that's typically an indicator that there's some sort of an infection going on. Individuals may also report some fatigue and lethargy, and they may even have a decrease in appetite. Chest discomfort would be more of a chest tightness, and if they have a cough, if they are not able to expectorate the fluid and cough it up, then they're going to complain of a dry cough and feeling kind of congested in their chest. Tachypnea and dyspnea are really common, especially if they are unable to cough up some of that mucus. So they may especially have shortness of breath with exertion, and this exertion could be simply walking from one side of the room to the other. A lot of this also depends on the patient's medical history as well. The diagnosis of pneumonia is typically first done with a chest x-ray, but we're also going to do a sputum culture. And we do a sputum culture to help identify what exactly the cause is. If it's a bacterial cause, well, what kind of bacteria is it? This helps to guide what kind of antibiotics are going to be most effective for the patient. We may also draw some blood, particularly looking at CBC. So we may want to look at white blood cells to determine infection, but we may also want to look at BUN and sodium levels to look at hydration status. ABGs may also be ordered in order to determine what the oxygenation status is. While you have a pneumonia patient in inpatient care, you're going to be doing frequent vital sign assessments as well as monitoring oxygen saturation and respiratory status in general. We also need to make sure that we're looking at immunizations. So have they been immunized for influenza, or now have they been immunized for COVID? And have they also received a pneumonia vaccine if they are of the appropriate age? Hand washing is going to be key with all of our patients in the healthcare setting because we don't want them to get something like hospital-acquired pneumonia. When individuals are discharged, you want them to be aware that they should avoid large gatherings because this is going to increase the likelihood of developing a flu infection, which could then predispose some individuals to develop pneumonia secondary to flu. So those who have a history of respiratory conditions, such as COPD, for example, they're going to be at higher risk for developing something like pneumonia because they have that respiratory history. Hydration is going to be very important. This helps to ensure that they are well hydrated so their body can fight off infections. And if they do get pneumonia, then it helps to thin the fluid so that they can cough it up. Now let's talk about silicosis, which is also an occupational pulmonary disease. This is typically going to be someone who had an occupation where they were around some sort of dust on a daily basis that they were breathing in. So things like mines or even working with pottery on a daily basis. And this is when there's going to be a nodule that will form in between the alveoli, and ultimately it will cause scarring, which is going to then lead to fibrosis. So it's a stiffening of the lungs, and then they lose their elastic recoil. So they're going to have a harder time breathing in oxygen. Typically with individuals who develop silicosis, it's not going to happen overnight. It's going to happen 1 to 2 decades or more after their frequent exposure. Some common manifestations are going to include shortness of breath, especially on exertion, and they may even have some weight loss. Oftentimes individuals will fatigue when they're eating, so this could be a contributor. Treatment is typically going to include symptom management and quality of life, so it's going to be very individualized for these individuals. Because they are going to be at higher risk for developing other respiratory infections such as flu or pneumonia, we want to ensure that they are receiving their vaccines to help prevent some sort of secondary infection. Those who have more progressed forms of silicosis may be good candidates for a lung transplant. Our general nursing interventions for someone who has silicosis is going to, of course, obtain a history of occupational or environmental exposures, and then determine when did they start experiencing their symptoms. Do they feel like it's staying the same, getting better, getting worse? And are they still around that environment where they were inhaling dust? If they are still working and exposed to that work environment, you would want to get social work involved to help provide more support in order to get the patient out of that work environment. They may need oxygen as needed, but that's also dependent on how severe the symptoms are for the patient. They may also be referred to pulmonary rehab as well. Now let's talk about tracheostomies or trachs. These are used when an individual has something obstructing their airway, maybe a severe infection, they could have a tumor, or even an injury of the neck or mouth. So some individuals may need this long-term, but other people may need it on a short-term basis. It just kind of depends on what the cause is. So this is going to essentially help to provide oxygenation for the patient. So they're going to be hooked up to a ventilator, which will help to essentially provide oxygen and help the patient breathe. With your trach care, it's really important to ensure that the airway is patent. So you need to ensure that you're assessing lung sounds bilaterally. If you hear that there are no lung sounds on one side, that would be a bad thing that you need to report to the provider right away. Typically, there's always going to be an insertion tray at the bedside for the first 72 hours, or depending on a hospital policy, if there's any complication with the original trach. An ambu bag will always be around. If there is an emergency situation, then you can have an ambu bag available if it's needed. Or even if a patient is being transported, they may be put on the ambu bag temporarily. You also need to assess for subcutaneous emphysema, which is a condition where air can become trapped under the skin. So it's really important to, again, assess for lung sounds and look at your patient's overall color. With your trachs, ensure that they are secured with their ties. If they're soiled, you need to change the tie because you don't want it sitting on the skin and then causing skin breakdown. Duoderm dressings can be used around the trach site depending on the skin status for that patient. So it's really important to assess the skin around that trach site. Sometimes we'll have to do suctioning for people with tracheostomies, and this is going to be mostly determined by the sound of the patient. So if it sounds like they have a lot of mucus buildup, then you're going to suction appropriately. Typically with these patients, you're also going to hyperoxygenate before you suction to help prevent hypoxia. Ensure you are not suctioning for longer than 10 to 15 seconds. If you do, then you can cause hypoxia for your patient. You may only be suctioning the trach, but you may also need to suction the mouth. It just depends on the individual. Also ensure that you are using aseptic or sterile procedure. The purpose of using aseptic or sterile technique is to help prevent something like ventilator-acquired pneumonia. So this is really crucial for your patients who are having suctioning performed. Now, what is hypoxia? Hypoxia is either hypoxemia or hypoxia. Hypoxia is just a decreased tissue oxygenation, whereas hypoxemia means that we can see that there's a lower level of oxygen circulating in the blood. This could be found with something like an ABG, so we may see that the partial pressure is decreased, and then the arterial oxygen saturation may also be decreased, depending on how we are measuring the oxygen blood levels in the patient. Now, people who have other respiratory conditions are going to be at higher risk for hypoxia. So people who have things like COPD or asthma, pneumonia, even someone who is very anemic can have symptoms of hypoxia because of that lower level of hemoglobin. Those who have sepsis or fever, because of the inflammatory response and the infection, they could also have hypoxemia. Hypoxia may lead to cyanosis, which is a blue discoloration around the lips as well as the fingers. So if you have an individual who is starting to act confused, they're irritable and restless, general change in LOC, those would all be indicators that there's something up with your patient and you need to assess their respiratory status, especially if you see a change in vitals. So they may have tachycardia and tachypnea. They're trying to breathe faster in order to compensate for the lower level of oxygen being brought into the body. Tachycardia is going to occur because the heart is trying to compensate for that low oxygen level. So it's trying to work a lot harder to circulate what oxygen is in the body. Typically, these patients will have things like shortness of breath, especially on exertion. If your patient is more bedbound, you may see a change in the breathing pattern. So are they breathing faster? Are they breathing more labored? Are they using accessory muscles? You also need to take a look at the mouth because you are looking for signs of cyanosis. If there's signs of hypoxia present, then you are going to closely monitor the pulse ox on your patient. It's non-invasive and it's something that can be done at the bedside. However, you may need to call the provider and have them order an ABG. Then RT will come and they will obtain the sample at the bedside for the ABG. You will stay with your patient if they are showing signs of hypoxia because you don't want them to decline even more. If they need oxygen, in which if they're hypoxic, they probably do, typically you're going to start off with a nasal cannula depending on how your patient's appearing as well as how low their oxygen status is. Venturi mask can be used up to 40%. So your individual, it depends on their needs for oxygen saturation. We want them to have an oxygen saturation of 95 to 100%. However, if your patient has something like COPD, then we're going to want them to be somewhere between 88 to 92 to 95%, depending on how severe their COPD is. Any patient that you have that is having an alteration in respiratory status, you need to ensure that you are doing frequent checks on your patient. Are they still breathing? Are they showing signs of hypoxia? Do you need to titrate their oxygen? You also need to look at things like their ears, especially if they have something like a nasal cannula on, because it can cause skin breakdown. We also want them to have oral care every 4 hours or as needed because that frequent flow of oxygen blowing into the oral cavities or even the nasal cavity can dry everything out, and then it can put them at higher risk for sores in their mouth. Lubrication with non-petroleum products into the nostril. And the reason for this is that petroleum products can be inflammatory. They are flammable. They should not be smoking or around any open flames because oxygen is flammable. They need to be repositioned every 2 hours. Obviously, if your patient's able to reposition themselves, that is ideal, but not all of your patients will be able to do that depending on their respiratory status. It's important to know your oxygen delivery methods. We have our nasal cannula, which is one of the more common ones, and you can administer up to 6 liters. If someone needs more oxygen, then you'd want to transition to a simple mask. It should never be below 6 liters on a simple mask because then your patient is going to breathe out that CO2 and then they're just going to breathe it back in. So their oxygen status is not going to improve. A non-rebreather is going to be the thing that offers the highest level of oxygen delivery. So this can be given at 10 to 15 liters per minute. So if you have a patient who is acutely declining with their respiratory status, they might need a non-rebreather. With your general interventions, you need to ensure that the oxygen is set appropriately and make sure that you are checking a reservoir bag for deflation with your non-rebreather. So this image here is a non-rebreather. If you see that it's deflated, then the oxygen is not turned up high enough. Our oxygen administration for our COPD patients is going to be just a little bit different. Because they have that chronically high CO2 retention, we can't give them too much oxygen because it can decrease what's called their hypoxic drive. Hypoxic drive is our natural trigger to breathe. If we give them too much oxygen, then they lose that hypoxic drive and their respiratory rate can decrease. So it's really important to monitor the respiratory rate, effort, and oxygen saturation. Our goal range for our individuals is typically going to be somewhere between 88 to 92%. That also depends on the hospital policies that you're at. Some will aim more towards 90 to 95%, but it also depends on how progressed your COPD patient's disease process is. They may also have frequent monitoring of ABGs to ensure that they are oxygenating appropriately. With our oxygen delivery, they may need a nasal cannula and titrate appropriately. They may eventually need something like a simple mask, but do note, typically we're going to try to avoid the use of a non-rebreather because that's a much higher level of oxygen that would be delivered. Now, what is pulse oximetry? Well, this shows hemoglobin saturation with oxygen, and we know our normal range is going to be between 95 to 100%. So this tells us if there's a change in the saturation before someone shows those obvious manifestations, such as the restlessness or the cyanosis or change in skin color in general. With pulmonary function tests, we talked about this with asthma, and this is going to evaluate the lung function, and especially those who have chronic conditions like COPD or asthma, how they're responding to therapy. Are they having exacerbations? Is their treatment method effective? Or do they need to have modifications to their treatment plan? Some other studies that we might be doing for our patients include things like a bronchoscopy, which could be used for our patients who have the need for further assessment of the internal airway systems. This can also be used if we need to obtain a sample in order to culture it. This is something that is done by a surgeon or a doctor. This is not done by the nurse. Skin testing is going to be done when we suspect things like allergic responses. So someone who has asthma, for example, doing a skin allergy test can help to determine what some of the triggers are for the patient in terms of how they're developing their asthma attacks. We may also need to do something like a PPD to determine if someone has something like tuberculosis. ABGs are typically done by RT. It's done at the bedside, and if you see this bottom left image here, this is a ABG using the radial artery. There are certain considerations for your geriatric population, and that is that, one, their lung defenses are not quite as good as they are when they're younger, and that is for several different reasons. So our older adults tend to be at higher risk for things like pneumonia because their respiratory muscles will decline, meaning that they are not going to be able to breathe in and out quite as effectively, but they may also lose some of their vital capacity, which is going to affect the amount of air that can be inspired. Our lung defenses, as I mentioned, can decline, and it's partially because of all of those changes. They may also have a decrease in the ability to exercise appropriately because they lose some of that vital capacity. So it's really important to ensure that older adults are still exercising, but perhaps are doing things that are a little more conducive to the needs of their own unique needs, especially if they have something like a chronic respiratory condition or if they have any cardiac conditions or even musculoskeletal conditions. So they may need to alter the type of exercise that they're performing. There are also some anatomical changes that can occur, and this is going to lead to the inability to really have that good elasticity to breathe in and out appropriately. Another really important thing to note is that coughing reflexes can be less effective. And this is another reason why older adults tend to be at higher risk for pneumonia, because they're at higher risk for aspiration type of pneumonia. But it also means that if they are exposed to something entering their airway, they may not be able to cough it up as effectively as those individuals who are younger. So again, with your older adults, it's really important to note that their cough reflexes will change as they age. So that means that they can't cough up mucus quite as effectively. And that also means that if they have something like pneumonia and they're taking, Mucinex to help loosen up some of that mucus, they may not be able to cough it up quite as effectively as someone who's younger. So they may be some of those individuals that would benefit from suctioning. With older adults, be mindful that when they have infections, they don't show signs of infection quite the same as someone who's younger. So they may have an alteration in LOC. So if they're suddenly confused, that should be a red flag for you. You're still going to monitor the respiratory status. So What's their oxygen saturation? Do they have normal breath sounds? Do they have any signs of cyanosis or any other signs of hypoxemia? Some people will underestimate the importance of an incentive spirometer, but it's your job as the nurse to ensure that your patient understands why this is so important. This helps to promote lung expansion. So this also helps to ensure that the patient is engaging those muscles in order to prevent things like pneumonia. This is particularly important for your patients who are bedbound or those who have recently had a procedure. With the device, ensure that you are having them do the teach back method because you want them to make sure that they are doing it the correct way. They need to be sure that they are inhaling versus blowing into the machine, because if they blow into an incentive spirometer, it defeats the purpose of the incentive spirometer. So you want them to inhale to expand those lungs. Pulmonary hygiene is something that can be done in several different ways. Incentive spirometry is it's not a very invasive procedure. It's something that the patient can do on their own. However, if your patient can't do an incentive spirometer, then they may need something like suctioning or even nasotracheal suctioning. Those who have other conditions may need something like a bronchoscopy. Positioning is another really big one. So this is where we're allowing gravity to do its job and help to drain some of the mucus. Cupped hand or vibrated chest is going to also help to dislodge the mucus. So with a cupped hand, you're basically taking cupped hands and then tapping along the back. And then with a vibrated chest, there are certain devices that can be used for this. So they actually have vibrating vests now that can be used, and this helps to break up some of that mucus so that one can expectorate it. And this concludes our pulmonary lecture. So if you have any questions as you're going through this and studying, please feel free to reach out to me.